Hey everybody, Milkman Al here. I've been super bad about uploading weekly videos like I'd planned on, but you know what? This past week, I was basically drunk playing Warhammer, so sorry not sorry. But in any event, today we're going to be talking about the case of Anders Pederson, who is a gentleman in his 30s who back in 2015 donated his kidney to his sister and then subsequently died during his hospital stay. Now, this case was presented to me probably about 3 weeks ago in the context of a nurse practitioner basically overstepping her bounds and making a huge error and costing somebody their life. Now, I think that was only part of the equation, and we'll talk about all of the things that essentially led up to and ultimately caused his death. Clearly a tragic situation. You know, this is a young, healthy guy who did something unbelievably nice for his sister, basically saved her life, and it ultimately cost him his own. So there's an excellent article from NBC Bay Area that more or less demonstrates all of the things that happened with Anders Pederson's hospital stay. So they have a pretty detailed timeline that I'll show you, and I'll link this article in the description so you can see it. But the brief summary of it is, so he goes in for this kidney surgery early in the morning. Most of the time, these donor surgeries are first starts. They call them first starts, which at most places is 7:30 a.m., just so they can coordinate things a little bit better, and the risk of, you know, some sort of emergency pushing it out of the way is lower, you know, because there's a little bit of coordination that has to happen here. Like, it's two people having surgery simultaneously. They want to take the kidney out of the donor and get it to the recipient as quickly as possible, because that, you know, basically as soon as you take the kidney out, it technically starts dying. And kidneys are incredibly metabolic organs, so they die quickly. So the faster that you can get it into the recipient, the better off everybody involved is. So anyway, we go through surgery. Anders and his sister, you know, both sail through the operation. Everything goes smoothly and according to plan. So if you look here, this is a documentation of all of the narcotics that Anders Pederson got. So reading through this to me right here, this 50 micrograms of fentanyl is, you know, just normal pre-surgery stuff. So basically everything from the 735 dose here through 1113 where it says surgery completed, that's all stuff that he got intraoperatively. So that's like the anesthesiologist or anesthesia team at least giving him these meds. And this is not an uncommon amount of medication. This is totally normal. 300 micrograms of fentanyl or 350 and 2 of Dilaudid. Like, that's a hefty dose for, you know, a healthy young person. Looks like he's pretty thin too, so, you know, on the lighter side. But it's a 4-hour surgery. Fentanyl doesn't last very long. Dilaudid looks like they just gave it up front, so he got nothing towards the end. That's probably also mostly worn off too by the time he's out of surgery. So PACU is the post-anesthesia care unit, or basically the recovery room. So he gets transported to the recovery room, and these surgeries, so donor nephrectomies, for some reason are very, very painful surgeries, like more painful than you would think that they actually should be. And the donors, from a pain standpoint, generally do pretty badly in my experience. They do require a ton of pain meds to keep their pain under control. Again, not entirely sure why that is, because like the kidney recipients do fine. They're generally, you know, they tolerate their surgery pretty well. Like, of course, it's surgery. It's going to hurt, right? But it's like an expected amount of hurt. So anyway, they order him something called a fentanyl PCA pump, as you can see here, right? So what a PCA is that stands for patient-controlled anesthesia. So here's what a PCA pump looks like. It's basically just a pump that you put either a syringe, this one's a syringe, sometimes they can be bags, of narcotic in, and it allows you to hit this button here that delivers you a set amount of pain medicine. So what they do is they program this pump, and, you know, there's a dose that you set, and there's also something called a lockout. So this button, the patient gets this button, right? So they can just hold this button and hammer it anytime they want. You can press it 20,000 times an hour if you like. But so what the lockout is it's the period of time where the pump will not give you a dose of medicine. So say like your lockout's 10 minutes, which is pretty typical for most drugs. So If your lockout's 10 minutes, you can sit there and pound that button as much as you want, but it will only give you meds every 10 minutes, okay? You can also do something called a basal rate on this, which basically means that it's continuously pushing medicine through the pump. Like, this is all hooked up to your IV, and you're getting pain medicine IV. So it can give you medicine continuously as well. Generally speaking, that's a terrible idea, because the benefit of these pumps is that if somebody overdoses on them, like if they're just hitting the pump and they get too much narcotic, the idea is that it's giving you a small amount of narcotic every time. And so if you kind of cross that threshold where, you know, you get too much and you just kind of pass out, it wears off pretty quickly and you just kind of like fall asleep and can't push the button anymore. But if you have a basal rate running, then it's still pumping you, narcotics even when you're asleep, and that can lead to catastrophic problems. And when I first heard this story, I was like, well, surely they put a basal rate on this pump. And actually, that isn't what happened, and we'll get into this in a little bit more detail in just a minute. Generally, these are extremely safe things to do. They're great because patients have more control over their pain medicine. They don't have to wait on a nurse to like go and get them a dose of medicine. And so generally, patients' pain is much better controlled with a PCA pump than just having to request medicines from their nurse. Generally speaking, people have what we call breakthrough medication. So if the PCA pump's like not quite handling it, they'll be able to ask their nurse for more medicine. But still, this is a great way to, take care of the vast majority of their discomfort after surgery. So now that we kind of know what a PCA pump is, we can get back to this record of the narcotics that Anders Pederson gets. And as you may be suspecting at this point, narcotic overdose is what ultimately led to this gentleman's death. So this fentanyl PCA pump gets ordered. I personally don't really care for fentanyl PCAs because fentanyl is so short acting that I find that patients don't really get the long acting pain control that they need. And that's even though when they hit the button, they do get some relief, they have to kind of continuously hit the button over and over and over to maintain that relief. And that makes it really difficult for them to sleep. And I just don't like it. I think longer acting narcotics work better. And the order here is pretty low. It's pretty stingy in my opinion. 10 mics per push is what I would consider pretty normal, but usually when I order one, I would do it every 6 minutes. So they would be getting a max of 100 mics of fentanyl an hour instead of 60. 60 micrograms of fentanyl per hour is not very much, especially when it's coming in 10 mics per push. So in any event, he gets some IV push fentanyl here. This is presumably still all in PACU and you can kind of tell, because all of these numbers are really close together and nurses on the floor, frankly, just don't have the bandwidth to do this, right? So he's getting medicines every, 2 to 5 minutes, and floor nurses just cannot sustain that. They have too many patients, they're overworked, and there's just no way that they could pay attention to somebody on the level necessary to do this. So this is all in PACU, right, in the recovery unit. So he's getting a fair amount of narcotics, Mordilaudid, which is another narcotic, in case you weren't aware. It's kind of a little bit longer acting than fentanyl is. He's just kind of in PACU, getting narcs. And this is all this 10 mic fentanyl stuff that's a PCA push. So he's pushing his button pretty frequently, right? It's got a 10-minute lockout on it, and he's hitting it basically every 10 minutes for all intents and purposes, right? Hitting that button, like every time he possibly can, he's hitting the button every 10 minutes. And it's kind of hard for me to tell when he leaves the recovery unit, but it looks like it's probably here-ish, so like 1 p.m., something like that. He got out of surgery at 11:40 and leaves PACU probably around the time where he starts hammering his PCA. So he gets to his room, pushes his PCA pump, he's doing this, and then we have this. So this is the order that the nurse practitioner did for his PCA. And this is what landed this case in the r/Noctor subreddit, which is a subreddit basically dedicated to highlighting the mistakes that mid-level practitioners make, maybe unfairly so. There are a bunch of people railing. A nurse practitioner ordered this, and there are a bunch of people railing on her for this order, which, to be fair, is a pretty stupid order, but we'll kind of go through why it's not quite as bad as a lot of people think. So 0.6 milligrams of Dilaudid. So even if you know nothing about Dilaudid dosing, which I'm assuming most of you don't, you'll see up here that he was getting half a milligram, right? Half a milligram. Those are his IV push doses from, nurses who are very experienced with this sort of narcotic dosing, right? These are PACU nurses. They give this all day long, every day. These are the doses that they're comfortable giving, and that's just a straight up IV push, right? That's a one-time sort of thing. So he has this on his pump every 15 minutes, just at his demand. Okay, so the point I'm trying to make here is 0.6 is a really big demand dose on a Dilaudid PCA. When I prescribe Dilaudid PCAs, I usually do 0.2 milligrams. I do 0.2 every 10 minutes. So I'd be giving somebody half this much Dilaudid. I'd be giving a max of 1.2 every hour. And so like I mentioned originally, when we were talking about PCA pumps, the nice thing about these is that if you reach that overdose threshold, you just kind of pass out for a little bit, okay? The problem with this is that since this is a pretty hefty dose, you can overshoot that threshold very substantially. Like with 0.2 milligrams, not so much, but 0.6, you can kind of go sailing past that, what we call the apneic threshold, where, so narcotics raise your apneic threshold and basically can make you stop breathing when you should otherwise obviously be breathing. So he gets this PCA order change, and that goes into effect, and he starts hammering that too, right? So he's still in a ton of pain, obviously, even all through the night. So every 15 minutes, he's pushing that, getting 0.6 of Dilaudid. And, he tolerates this for a long time. And part of the reason I don't think that this order is quite as dumb as Reddit seems to think is that he's a young, healthy guy. And, even though he has a solitary kidney now, which does sort of affect your opioid metabolism a little bit, but he had a very painful surgery. He's a healthy guy. And, he's been on this PCA for all night, right? Quite a while, and he's doing well with it. Like, he can tolerate a fair amount of narcotics, even though presumably he doesn't take narcotics regularly. Again, that's a huge dose. It's twice as much as I would give somebody and kind of dosed in the wrong way, in my opinion, but this isn't, negligent malpractice territory at all, in my mind. It's a lot, it's a hefty dose, and more than I would give, but still not terrible. So, he's getting Zofran. This is a anti-nausea drug that works really well. So he's nauseated. All of this narcotic is getting into his stomach, which is expected. It's normal. Also, he had abdominal surgery, so that can make you nauseated as well. Just anesthesia in general can make you nauseated. So he's got a lot of reasons to, barf his guts out right now. That said, that's a huge problem because he did have abdominal surgery, and heaving, when you have a big abdominal incision, really sucks. So here's where we get into the shit, right? So here's the last few doses that he had, right? So 8 a.m., 8:32. And so you snap back to this article here where they have their timeline. This says, Anders asks his mother, Melissa, for sunglasses so he can sleep, because this is in the morning, right? This is 8:45 in the morning. So she snaps a photo of him. He's sleeping. Everything's cool. So he reached that, pass out stage, right? He's going to sleep. And everything's cool. He was up through the night, pushing his PCA button, obviously in a lot of pain. So he needs some rest. And shortly thereafter, his mother notices that he's turning blue, and he's cold, and he doesn't seem to be breathing. And this is about half an hour later. She notifies the nurse. They call what's called a code blue, which is basically an emergency resuscitation for this patient. And basically it's too late. So they manage to revive him, but has what we call an anoxic brain injury, which is basically just lack of oxygen delivery to your brain, so your brain basically dies. So he's brain dead. Lasts, I think, about a week before they decide to withdraw care, and he subsequently dies. So this is obviously terrible. Young, healthy guy, like we said, dies doing something very, very valorous for his sister, and the world explodes. Like, what the hell happened? There's tons of review processes in hospitals for events like this. And, clearly this is going to get a lot of scrutiny. And it did. So here we are 7 years later, and back in early May, a judge determined that there were numerous medication errors or medical errors that led to this patient's death, as the title of this article would indicate. So in my mind, the main thing that was the problem here is not the dose of Dilaudid that he got with his PCA pump, though that was definitely a problem because, as we kind of covered earlier, Dilaudid is a little bit longer acting than most narcotics, so you can kind of stack those doses pretty easily as time goes on, and not give them chances to wear off, which is exactly what happened to him. But there are supposed to be safeguards in place for that. So when you have a PCA pump, you're supposed to have your pulse oximetry monitored, which basically means that we're watching how much oxygen is in your blood. And you also have something called a capnography monitor, which is like a little thing that you breathe into, and it like registers on a monitor that shows that you're breathing out carbon dioxide. And he had neither of those things. I have never seen a patient with a PCA pump that didn't have both. Never seen that. That is a huge breach of standard of care in every institution that I've worked in. And this happened at UCSF. I have no idea what their policies are, but I cannot imagine that they don't include pulse oximetry and capnography for PCA patients. Because frankly, doing anything other than that is just stupid, as was demonstrated, right? So he wasn't properly monitored. There was some issue with the nurse on the floor not measuring his vitals in a timely fashion, and also not carrying out an order from the doctor to have his capnography and pulse ox monitored. So there's a lot going on here. And like, in my opinion, again, I don't think the PCA pump orders were like heinously inappropriate. I don't think they were dangerous. But if this patient had been monitored properly, they could have fixed that problem, right? There'd be alarms going off. Somebody would have run into his room as soon as he stopped breathing, been able to mask him up, give him a drug called Narcan, which basically reverses opioid effects, and he'd be fine. Maybe he would have stopped breathing for a minute or two while everybody kind of got their shit together, but like, that's not fatal. Healthy people can hold their breath for a minute, a couple minutes, but those alarms start going off pretty much immediately. So there's not a lot of lead time until we would have been alerted to the fact that he was struggling and he was in, a dire situation. But since he didn't have those monitors, we wind up with a dead young patient. And that sucks. This tragedy could have been easily avoided. I think this is a very good article, but I wanted to kind of discuss some of the more technical aspects of it. So hopefully that all made sense to you guys. So as I alluded to earlier, anytime in medicine we have a catastrophic screw up like this, we have something called a morbidity and a mortality conference to kind of evaluate and discuss what happened. Generally, we'll have something called a root cause analysis to figure out why exactly these things happened and what we can improve on. So let's do a miniature version of that here. So like, what could have been improved on with Anders Pederson's case? So first off, the most obvious thing is the monitoring that I've talked about. This is just a obvious standard of care at every place that I've ever worked. I don't know why you would ever not do it. It's totally harmless. It's a huge safety measure. There's no reason to not do this. So the fact that the pulse oximetry and capnography had been ordered for him and not performed, that's a just absolutely catastrophic, can never happen sort of event. The other thing that, in my opinion, could have been done much better is this patient could have been offered alternative forms of pain control. So we scrolled through his narcotic log, right? And he's just hammering his PCA pump the entire time. But there are options that are very helpful for post-op pain, especially in his case. So first off, you could have done an epidural for him. Most people think of epidurals as just available for pregnant patients, like people who are in labor, but they're really, really good for everything from thoracic surgery to abdominal surgery and indeed labor. So that would have been a great option to control his pain without using narcotics. There's another option that might have been better. You can't place an epidural in somebody who's anticoagulated, and a lot of times patients who have their kidneys out are getting heparin or have gotten heparin, and so they wouldn't be a candidate. And in that case, you can place something called a transversus abdominis plane block, or a TAP block. And what that does is it basically just goes in the wall of your abdomen, and you can even run a catheter there. You can run a little tube and just continuously give them numbing medicine directly to the nerves that are all around the surgical site. And again, that does not involve narcotics, so it's just a nice way of numbing his surgical site. and hopefully decreasing how much pain medicine he needed in the first place. So even if, for whatever reason, you had left his PCA pump at the extremely high dose that the nurse practitioner ordered, maybe he wouldn't have been pushing it enough to cause himself respiratory depression and ultimately respiratory arrest that led to his death. Those, to me, are the options that stand out as kind of obvious, honestly. We did tap blocks and sometimes epidurals for just about every single kidney donor that we had in-house. And they, again, did fairly poorly overall with their pain, but those blocks helped them immensely. You would think that a huge center such as UCSF would make use of options like that. They certainly have the availability to do that. They've got tons of anesthesia residents running around all over the place who they can send up to the floor to do those blocks, no problem. Or just do them in the recovery unit, which is what we did. In any event, I hope you guys found this interesting. I hope you found it informative, useful. Again, don't hesitate to join the community. Come by Discord, come chat, join us live, and don't forget to like and subscribe. So until next week, I'm Milkman Al. I'll see you then. Thanks for watching.